Hey, Dr. Sanjay. Hello. हाँ sir, good afternoon.
Good afternoon, sir.
Good afternoon, sir. How are you? Yes. I think I have WhatsApp you the schedule for next 4 lectures on WhatsApp. Sir, you are not audible.
Anand, are you there?
Yes, sir. Good afternoon.
Sir, good afternoon.
आनंद।
जी गुड
हेलो
आफ्टरनून सर।
दरिया साहब।
सर कैसे हैं आप?
Good afternoon, Dr. Daria. You are
सर गुड
looking,
आफ्टरनून।
you are looking fresh from your Amsterdam trip.
गुड आफ्टरनून।
हाँ अभी जेट लैग ठीक हो गया सर। अभी
Eh?
जेट लैग खत्म हो गया सर। अब 2 दिन हो गए।
But you must have been accustomed to jet lags, na?
इट्स नॉट लाइक दैट सर।
Sir, I think I have sent you the schedule for next 4 lectures on your WhatsApp.
Yeah, I got it, sir.
Yeah, yes, sir.
I
Yeah.
got it.
इनके फोटोग्राफ्स और क्रेडेंशियल्स भी भेज दूंगा सर अभी मैं। स्पीकर्स के चारों के,
हाँ,
जो चारों नेक्स्ट स्पीकर है उनके क्रेडेंशियल और फोटोग्राफ में भेज दूंगा अभी।
ठीक 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 ठीक। हम लोग इधर क्लास ला रहे, इधर इधर सीएमई, उधर सीएमई, यहाँ जाइए वहां जाइए, ये भी बहुत चल रहा है।
हाँ ये भी है सर।
अभी कैसा सर? अभी टेम्परेचर बढ़ गया होगा बिहार में?
जी।
It must be quite hot in Patna and Muzaffarpur and
Well,
Bihar.
it is hot, not very hot. It is
Okay.
hot. It has started.
Not Jaipur is touching around 35 degrees Celsius.
सर 35 तो कल शाम को 4 बजे भी था।
हाँ,
आज शायद एक और बढ़ गया होगा।
अच्छा।
यहाँ भी अनप्लीजेंट नहीं है, हवा भी बह रही है, हवा भी है थोड़ी, इसलिए ठंडा रहता है।
हम्म।
So now we can start, is it not?
Yes, yes.
यस सर। सर इनकी रिकॉर्डिंग्स भी रहेगी ना अपने पास?
हाँ रहेंगे रहेंगे। एक दो आदमी मना कर दिए थे, लेकिन बाकी लोगों की रह रही है।
नहीं नहीं हमारी तो रख लो।
हम भेज रहे हैं सबको, इसमें आईसीपी के वेबसाइट पर धीरे धीरे वहां पर। आनंद,
जी सर।
शुरू शुरू किया जाए।
यस सर। नो सर प्लीज स्टार्ट।
Now it is 2:30, so I think we should start now.
Sir, I think you can start the program, sir, with your words of wisdom to the PG students who are attending these classes in benign hematology.
Thank you, sir. Actually, these classes are started for postgraduate students because what I realized that most of the medical colleges have got no faculty as it should be. So most of the students are devoid of these all type of teaching. Keeping in mind that idea, I started the teaching of this type in which all subjects should be covered. And today it is a session of hematology. Dr. Sudhir Mehta, one of the renowned hematologists, is going to start his lecture now on platelets. Dr. Mehta, please.
Thank you very much, sir. And good afternoon to all the attendees of this lecture series in the field of benign hematology, which has been a great brainchild of Professor Tiwari Saab. Now, as we all know, the platelets are the smallest component of the cellular component of the blood, but they carry the greatest responsibility of hemostasis. And because of their role in hemorrhage, thrombosis, and inflammation, therefore, the platelets and the various parameters of platelets, they attract the attention of doctors across all specialties. Not only that, the platelet count specifically attracts the attention of the patients and the attendants also. So many times what happens that the patient visits a doctor, whenever they go for a routine health checkup, they find that in the CBC report, platelet count is altered. Either it is low, it is high, and this is one of the reasons for referral for visiting the doctor in the hospital or in the clinic. So to start with this lecture, I'll just discuss the two case scenarios. A 45-year-old male who came for annual health checkup. He had no symptoms, no disease. All his blood biochemistry and imaging were normal, except for platelet, which was low in the CBC report. So this is the patient. Then he was referred to the hematologist for the opinion. We'll take up this case once again in the course of my lecture. Another case scenario is there's a routine health checkup of a senior bureaucrat who belonged to West Bengal state, and all his reports were again normal. He had no comorbid conditions. He was hale and hearty, but again his CBC showed thrombocytopenia at 85,000. So these are the two situations which very often a doctor sees a patient or his attendants that they have no symptoms of whatsoever disease they have, though they do not have, but the platelet count is low. So the platelet count, in fact, counting of platelets is a very challenging task. Even today, with the best of technology, ensuring accuracy and precision of platelet count remains a challenge with the best of labs all over the world. And this happens especially when there is severe thrombocytopenia or there is marked thrombocytosis. Now, these challenges in
Your slide is not
Sir, your slide is not moving, sir. Your slide is not moving.
It is moving here. Is it not moving?
No.
I think I'll stop sharing and again start. Is the IT person is there?
So first of all, sir, stop the slide and after that, open the slide, sir.
Okay,
Then
again I'll do it. Yeah.
Sir,
Is it
present
moving?
slide mode, sir.
It's moving?
Yeah, that's
yes.
okay.
So I'll just repeat. I think I was talking about the two case scenarios where the subjects had come for annual health checkup and they had no symptoms, no disease, and all their blood biochemistry as well as imaging modalities were within normal limits except for the platelet count, which was low in the CBC report. So this was the case one, and this was the second case because the senior bureaucrats, they undergo annual health checkup. And this was about a senior bureaucrat who originated from West Bengal, and all his reports were normal, but the platelet count was less, around 85,000. So these are the two clinical problems actually, which if every physician faces in their hospital and clinics, and it requires before you label these thrombocytopenia as pathologic, it is very essential that one should recheck and see, is it a false thrombocytopenia or spurious thrombocytopenia? Now, the counting of platelets is a challenging task, even in the best of labs across the world. To ensure the accuracy and precision is a very difficult task, and especially when in the states where there is severe thrombocytopenia or there is marked thrombocytosis. Now, these challenges, most of the automated analyzers which deliver the reports, they work on the impedance method, that is the Coulter principle. And they usually provide accurate and precise measurements, but it's only when the platelets are normal. When the platelets are altered, either there is a severe thrombocytopenia or marked thrombocytosis, this precision is limited. And especially in severe thrombocytopenia, because the number of platelets are so low that they could not be analyzed properly, and this leads to inaccuracy in the platelet counting. Now, platelets are much more difficult to count than WBCs and the RBCs. The reason is because, which I'll explain later on the course of my lecture, the platelet count in the impedance method, they overlap morphologically with the debris, instrument noise, fragmented cells, bacteria, and small red cells. Moreover, the platelets are very active cellular elements. They have a propensity to activation. They adhere to the glass, to the foreign body, to one another within a short period of drawing a sample. So today in my teaching lecture, in the first part, I will just give you an overview of the platelet counting technologies. These technologies are very important to understand why there are false reports of platelet count in clinical practice. And then secondly, I will discuss the various factors which influence the platelet count. We all know that CBC is a vital parameter, essential baseline test in modern medical practice, and the platelet parameters is one of the important components of CBC. The abnormalities of platelet count and function occur in disease across all specialties and subspecialties. The platelet count is very crucial, especially in critically ill patients and ICU patients, because it affects the decisions regarding transfusions, any invasive interventions, as well as it is an important prognostic factor for critically ill patients. Along with the development of technologies as far as platelet counting is concerned, the transfusion services have also evolved over the time, and now we have transfusion services which are offering single platelet donor platelets in patients who requires platelet transfusion as a result of severe and symptomatic thrombocytopenia. Now, coming to the first case which I discussed, a 45-year-old male who came for annual checkup and his platelet count was 16,000, and he was referred to a hematologist. Now, this subject was seen by the hematologist, and all he ordered was the examination of the peripheral smear. And this, what you can see, that there are the clumps, large clumps of platelets in the peripheral smear. Presence of large platelets in the peripheral smear is suggestive of normal platelet count. And now we'll take what is this pathology. This is basically a platelet agglutination, which has occurred because of EDTA, that is EDTA-induced platelet clumping. Coming to the second case of a senior bureaucrat who had thrombocytopenia, and all of the tests were normal. This was the peripheral smear. On examination, you could find the large platelets are there. Now, these presence of large platelets leads to underestimation of the platelet count with the routine impedance method, which is there in the automated cell counter. So this person was a case of pseudo mega thrombocytopenia. In these platelets were actually normal because of the large platelets. The impedance method could only underestimate the platelet count. Now, a few things about the platelets. We know it is an anucleate small disc of plate-like with a volume of 2 to 20 femtoliter, and its normal value is 1.5 to 4.5 lakhs. And it has a lifespan of nearly a week. And these platelets are produced from the megakaryocytes as a result of stimulation by the hormone thrombopoietin, which is largely released from the liver, and to some extent it is also released from the kidneys. The platelet counts have slight diurnal variation. It increases with physical activity, and women and smokers have higher count as compared to males and non-smokers. Now, the platelet counting technologies have evolved over the years. To begin with, it started with the examination of the blood films. Then came the counting chamber concept in 1953, which was Breacher was the person who started this technology. And in 1970s, there came the automated cell counters with impedance method. They were working on the Coulter principle, which I will narrate later on in my course of my lecture. And subsequently, with 1980s came the two-dimensional fluorescence or optical method. And now, then in the last part of the 20th century, we had the flow cytometry, which were detecting the platelets and RBC ratio by using the monoclonal antibodies, which are directed against the platelet epitopes. And now in the 21st century, we have automated cell analyzers, which are not only fully automated, they have combination of flow cytometry as well as the two-dimensional optical system. And these the methods are now very precise, and the coefficient of variation is practical in the normal subjects. Now, coming to the microscopic methods, the counting chamber was first described by Breacher in 1953, and it remained as a reference method for platelet counting for many long decades. Now, this platelet counting by this chamber method is not only laborious, but it is imprecise and there's a poor reliability. And the inter-observer variation is to the tune of 10 to 25% in normal samples, and goes up to 40% if the samples contain less number of platelets. However, this method is, of course, used in few laboratories when you find that there are atypical platelets like giant platelets present in the sample, and this is used for manual counting of the platelet. Another microscopic method which we commonly use is in the present clinical practice is the method for manual platelet counting. Now, this is based on three different parameters. Either you calculate the ratio of the observed platelet to dead cells, and the TRBC is enumerated by the automated cell counter using the impedance method. Or you can calculate the ratio of the platelet to leukocyte count. Again, the leukocyte is determined by the automated cell counter. But more commonly, which is followed by the pathologist, is that you examine the 10 oil immersion fields on the peripheral smear, calculate the total number of platelets, and multiply by a factor of 2000, which gives you an approximate platelet count. Now, in the microscopic method, there was a refinement as far as the microscope was concerned, and with the advent of digital microscope, this method of platelet counting became more reliable because it was able to avoid artifacts which were generating over or underestimation of automated platelet counts. It was more efficient and more accurate, and this mainly because of the high resolution scanning of the peripheral smear. But in 1953 and 1954, Coulter invented the automated cell counter, and which worked on the principle of Coulter, which is named after him, the Coulter principle, and it's also known as the impedance method. Now, in this method, what happens? The platelets and the RBCs, they are counted in the same channel in the automated cell counter, but they are discriminated on the basis of the cell volume. Now, as I've already told you in my second lecture, when we are talking about the XYZ of the CBC, the platelets histogram, all these cells and fragments on particles which are between 2 to 25 femtometer, they will be counted as platelet, irrespective whether they are platelets or they are any other particle like bacteria or lipid particle or so on, or maybe small fragments of RBCs. Likewise, in the RBC histogram, all particles, including the RBCs, between 25 to 250 femtometer will be counted as RBCs. Now, this method of impedance, it is a one-dimensional histogram, and this is a good method to estimate platelet count, provided there is no extreme degree of thrombocytopenia. The moment the platelet count falls below 50,000 and more specifically below 20,000, the impedance method does not give you a precise platelet count. So the impedance method can result in overestimation or underestimation of the platelet count. And I've told you already, because the cell counters which are working on impedance principle, they also count the non-platelet particles as platelets if they fall in the range of 2 to 25 femtoliter. Now, conversely, a false decrease in platelet count be observed if there are large platelets are there, because these large platelets will follow in the RBC histogram and therefore will not be counted in the impedance method. And that's why the impedance method, whenever there's a marked alteration of platelets, the impedance method does not give you a precise and accurate platelet count. The second advancement which occurred in the technology of platelet counting was the introduction of the optical platelet counting. Now, this was a more better way of counting with the automated hematology analyzers, and this was based on the light refraction. And it was seen that based on this principle, the large platelets were discriminated from the small RBCs. In the impedance method, what happened that the large platelets were counted as small RBCs, and conversely, the small RBCs or fragmented RBCs were counted as platelet, and that lead to inaccurate platelet count. Now, with optical method, this method was much better than the impedance method. Then advancement in technology came the fluorescent platelet counting method. In this method, the fluorescent dye is used to stain the reticulocytes and the platelets, and the simultaneous measurement of fluorescence and scattered light gives you a more specific recognition and a more accurate count of platelets. And this is particularly true when large platelets have to be distinguished from other relatively large particles like fragmented RBCs, small RBCs, and other non-cellular particles. Now, this method has uniqueness that this also measures the fraction of young platelet, the so-called reticulated platelets or immature platelet fraction. Now, I think I have already discussed this in one of the early lectures. Now, this measurement, this peripheral parameter of platelet is very sensitive to what is happening to the megakaryopoiesis in the bone marrow. And this parameter increases when there is increased platelet destruction or consumption. And this parameter decreases when in the state of bone marrow failure, when there is a reduced or absent megakaryopoiesis. Then with further advancement and with the use of monoclonal and with antibodies, what has happened is the immunological platelet counting. This is now the gold standard for platelet counting and has been endorsed by the international societies. Here the platelets are labeled by the FITC conjugated monoclonal antibodies, which are against the CD41 and 61, which these are the two antigens which are present on the platelet membrane. And with the help of flow cytometry, it is able to calculate the ratio of fluorescent platelets to the RBCs, which are contained in the same sample. And the reference platelet count is calculated by this ratio. And the RBC count, as I already told you, it is determined by the impedance-based automatic cell counter. Now, this method is very sensitive to give a platelet count when the platelet count is less than 20,000. And in fact, it is a reported equivalent to the reference method in almost all cases, except in Glanzmann's thrombocythemia. This immunological platelet counting is not applicable in Glanzmann's thrombocythemia because in this disease, these epitones CD41 and 61 either reduced or are absent on the platelet surface. Now, this cartoon shows the relationship between the automated optical and the immunologic platelet counts. Now, one can see that this is on the y-axis is the automated optical method, and this is the immunological platelet count. The automated optical method, it overestimates the platelet count as compared to the immunological methods. Now, the current generation automated cell counters, they use both optical as well as the immunological counts, and therefore the platelet counting by these two methods in the most sophisticated automated analyzer gives you a very precise when there is even extreme degree of thrombocytosis or thrombocytopenia. So coming to what are the causes of false or spurious low platelet count or pseudo thrombocytopenia? Among the four which are listed, the three important ones are the pre-sampling technical errors, EDTA-induced platelet agglutination, in which was related to the first case which I have said, and the presence of large platelets, which was related to the case 2, which I showed you earlier. Now, sampling error is the most commonest pre-analytical error in our clinical wards and hospitals. Now, we all know that there are certain things which affect the platelet count. If the drawing time is prolonged while drawing a sample for platelet count, or there is inappropriate mixing, ideally, once the blood sample is drawn in the vial, it should be inverted for 8 to 10 times, but it should never be shaken. So vigorous shaking again causes change in the platelet count. Many times the vials are either underfilled or overfilled, or the sample is taken from the IV line itself or very proximal to the IV line, thereby causing the dilution. So these are the four ways by which because of the pre-analytical error and error in drawing the sample can lead to false thrombocytopenia. Now, clumping, which occurs either because of these technical sampling errors or which occurs because of EDTA, is the commonest cause of pseudo thrombocytopenia in clinical practice. Now, just to illustrate this importance, this is about a 60-year-old male who was posted for spinal surgery because of port spine. Platelets was only 56,000. The peripheral smear was checked and it showed no clumps. Platelets again appeared low. But the previous 6 months report showed that platelets had more than 2.2 lakhs. This patient was on multiple drugs, but none of the drugs were responsible for thrombocytopenia. And therefore, the surgery, because of thrombocytopenia, the surgery was postponed, and this case was referred to the hematologist. So next day, when the patient was seen by the hematologist, he ordered a repeat sample. And the repeat sample, what happened? They showed a platelet count of 2.22 lakhs. The reason was that when they examined the older tube, which was taken a day before, they found that there was small blood clot adherent to the vial. So the sampling error is very, very common in a clinical practice, and is very important as far as if you are taking a blood sample for platelet count, one has to ensure that the sampling should be very fast with a single clean prick, and the vial should not be agitated, should be inverted 8 to 10 times, and it should be immediately sent to the laboratory for analysis within 2 to 3 hours. And the second important cause of pseudothrombocytopenia is the coincidence error. That is, when 2 or more platelets or RBCs, they are registered as a single pulse. But now with the highly sophisticated analyzers, these errors have been removed by pulse editing, and therefore now it does not have any impact as far as the clinical practice is concerned. The second important cause of pseudothrombocytopenia is the EDTA-induced platelet agglutination. Now, this is an in vitro phenomena. It does not occur in vivo. Its incidence is quite rare, 0.07 to 2.2% of the routine samples. But in hospitalized patients, it is seen up to 0.1 to 2% of patients. And in fact, it constitutes nearly 1/5 of the referral to the hematologist for thrombocytopenia. And there are certain conditions which are unusually sensitive to develop EDTA-induced platelet clumping, and these include the antiphospholipid syndrome, lupus, pregnancy, sepsis, TTP, and myelodysplastic syndrome. Now, This phenomena of EDTA-induced platelet clumping is mainly caused by the presence of patient's antiplatelet antibodies, the effect of which is facilitated by EDTA, and preferably between the temperature of 0 to 25 degrees Celsius, that is in the EDTA tube. And this can be partially reversed by warming the blood sample. Now, these antibodies are directed against the glycoproteins, which I've already said, against the epitomes CD41 and 61, which are revealed upon the platelet in contact with the EDTA. Now, because of this interaction of EDTA with the epitomes, it causes platelet activation via the tyrosine kinase, and this leads to clumps and false thrombocytopenia in vitro. Remember, this type of activation occurs only in vitro in the presence of EDTA. It has no relationship with increase in platelet activation, which is involved in the pathogenesis of arterial thrombosis. And this type of thrombocytopenia is never accompanied by any bleeding signs. Now, the presence of these clumps varies over time for a given patient. It's not that the patient will have this phenomena every time when the blood is drawn for the CBC and platelet counting. It is at times there will be periods with clumping, alternate with periods without clumping, and there is no obvious explanation for this phenomenon. Now, when to look for platelets? There are 4 situations when the clinician or should ask the pathologist or the hematologist will look for the platelet clumps. Number 1, as you have seen the CBC printout, the 4th component of the CBC printout contains alarm, alert, or messages. These are the alerts which the machine generates, and these are to attract the pathologist that there is something wrong with the cell, with the 3 components of the cellular components of the blood, that is the platelets or WBCs and RBCs. And so under the platelet alarm or alert, you can find abnormal distribution of platelets, clumps is there, abnormal platelet scattergram, and so on. So when you have this type of reading coming on the printout of the CBC automated cell counter, one should always look for platelet clumps. The second important indication is when there's a past history of platelet clumps. And third important is if there's a decrease in platelet count by more than 50% for the adult and 30% of a child when compared with the previous results. And fourthly, one should look for platelet clumps if there's a thrombocytopenia observed either in the initial investigation or appearing during follow-up of the patient. So these are the 4 situations where if you have thrombocytopenia, one should always try to look for platelet clumps, because these are the cases probably in these circumstances that these could be the cases of pseudo or spurious thrombocytopenia. Now, how to search for platelet clumps is very important. The best way is to draw a fresh blood film from a finger prick and then stain with the Giemsa stain, and you look for, and you can count, which I have already enumerated. And now these, if you want to define how the platelet clump should look like, there should be a presence of at least 5 attached platelets to define a clump. Now, if you find a rare clump, it simply indicates there is a sampling error rather than EDTA-induced platelet clumping, because in EDTA-induced platelet clumping, there would be large clumps in the fringes and edges are always there. So if you find a single clump in the thrombocytopenia thing, probably it is the blood has not been drawn properly for investigation, and you find large clumps, and there are 2 or 3 clumps, especially at the edges of the peripheral smear, always think of EDTA-induced platelet agglutination. The 4th mechanism of which pseudo thrombocytopenia can occur is the phenomena of platelet cytolysis around the RBCs. Again, it is an in vitro phenomena. The platelets, they adhere to the neutrophils. Again, it is a rare phenomena. Usually it is idiopathic, but can be seen in patients with chronic lymphocytic leukemia or autoimmune disease. Its clinical significance is usually not much known. And again, the GP2B and 3A glycoproteins on the platelets and the CD16 are implicated in this phenomena. And one can always find out this clue looking at the RBC histogram, where if you look at the WBC histogram, sorry. So you'll find the abnormal localization of the neutrophils. The neutrophils, I've already told you in my previous lecture, they are the largest cells, and therefore in the WBC scattergram, they are to the right extreme of the histogram. And if you have an abnormal localization of neutrophils on the WBC scattergram, then you should think of this phenomena. But this phenomena carries little clinical significance and usually do not account for spurious thrombocytopenia, which is commonly seen in our clinical practice. So, the fifth important cause of thrombocytopenia, which is false in nature, is the EDT-induced platelet neutrophil agglutination. It is the exaggeration of the previous phenomena. It causes not only low platelet count, but also causes high WBC count. And they usually appear in thrombotic or inflammatory conditions like TTP, sepsis, and DIC, and because of the enhanced expression of the P-selectin on the activated platelets. The third important cause, which I also referred to one of the case number 2 in my beginning of my lecture, was the presence of large platelets, a phenomenon which is known as macrothrombocytopenia. Now, it is one of the commonest cause of pseudothrombocytopenia after sampling error. And this can cause the platelets to fall even below 30,000. And what happens, the large platelets are usually counted between 2 to 25 femtoliter in the automated cell count. So these larger platelets, which are around 30 and more, they are counted in the RBC histogram. Now, this phenomena can be seen in normal person. And these are the patients who have actually Harris syndrome. They have normal platelet count on manual testing. There is no bleeding. MBP is high. If the BLCR, which is indicative of large platelet, again is very high, and the platelet functions on aggregation studies is normal. And this phenomenon, of course, can be seen in myeloproliferative disorders or myelodysplastic syndromes. And similar phenomena can be seen when the megakaryopoiesis is recovering from any insult. This could be because of chemotherapy or any infection. Then coming to Harris syndrome, I've told you that the case number 2, which I've talked about, a senior bureaucrat, he belonged to West Bengal. And this Harris syndrome was first reported in 2002 in the American Journal of Medicine, that nearly 30% of the asymptomatic blood donors in West Bengal had thrombocytopenia on automated cell counters. There were large platelets were there, but these patients had no bleeding tendency. The aggregation studies were normal, and this condition does not require treatment. It's basically a variation where they have large platelets, and therefore every time these patients, the sample is subjected to automated analyzers, they would have thrombocytopenia. Of course, the manual counting will always give you a normal platelet count. The other phenomena by which platelet counts can be reduced falsely in various clinical conditions include the platelet phagocytosis by monocytes and neutrophils. But this is rarely of a significant sufficient degree to cause low platelet count. Now coming to the spurious pseudothrombocytosis or pseudothrombocytosis, high counts, platelet counts. If you recollect the histogram, that is the platelet histogram and the RBC histogram, both the cells are counted in the same channel, and therefore the platelets are counted in the channel between 2 to 25, and the RBCs are counted between 25 to 250 femtoliter. So if there are very small RBCs, severe degree of microcytosis, is it because of thalassemia, because of fever iron deficiency, or there could be fragmented RBCs, or there could be microspherocytosis, which is commonly seen in patients of acute burn. What will happen? There's all these fragments, RBCs fragments, they will be counted as platelets, and therefore this will lead to pseudothrombocytosis. Likewise, the cytoplasmic fragments of WBCs and nucleated cells again will be counted in the platelet channel, and therefore leads to high thrombocytosis. Then there are other particles like microorganisms, bacteria, candida, malaria, even the blood samples which are drawn after meals, or patients who are on total parenteral nutrition, or who has received L-asparaginase, or the blood having cryoglobulins, or even the air bubbles or debris in the bloodstream can all be counted as platelet, and therefore they will lead to high platelet count, and which can be of course rectified by looking at the peripheral smear. Therefore, it is very important that both pseudo thrombocytosis as well as pseudo thrombocytopenia should be ruled out before you further investigate for the altered platelet count, because many times if you miss this concept of factors causing spurious high or low platelet count, there would be unnecessary investigation, and finally you'll end up nowhere. Now, this is again an example of a 40-year-old man who had severe burn. Now you can see the platelet count is 2.74 lakhs. But if you examine the peripheral smear, there are a lot of microspherocytes are there. Now all these microspherocytes have been counted in the platelet channel, and therefore this has led to spuriously high platelet count. And the manual platelet count in this patient with severe burn was only 85,000. So it's very important that what is the clinical scenario, and why, and what is the report, what do you see on the platelet counting on the peripheral smear as well on the CBC printout, then you can make a diagnosis. Is it because the platelet count has been altered falsely, or it is because of some organic disease? This is what I've shown you earlier. If you have very fragmented RBCs, small RBCs, severe degree of microcytosis, microspherocytes, what will happen? The descending limb of the platelet histogram does not touch the x-axis. It merges with the RBC histogram, which is to the right of the platelet. And therefore, this is whenever you see this type of configuration of the platelet histogram, always think of possible causes. Either there are platelet clumps are there are very fragmented RBCs are there, extreme degree of microcytes are there, or there could be large platelets could be there. So looking simply at the WBC histogram, one can also make a diagnosis of spurious thrombocytopenia. Then there are other cytoplasmic fragments of WBCs and nucleated cells can also cause alteration in the platelet count, especially in patients with acute leukemia, the leukemic blast, inherited cell leukemia, and these they can all cause false elevation of the platelet count, and that's why many times these conditions are usually associated with thrombocytopenia. But if you do not neglect this cause of false thrombocytopenia, thrombocytosis, then one can be misleaded, and there would be under transfusion of critically ill patients, especially with patients with acute leukemia. Likewise, the microorganisms like bacteria, candida, and malaria all can cause change of platelet curve and can lead to the high platelet count. Lipids, especially if the blood sample is drawn after the meals, or patient is on TPN, or a patient has received L-asparaginase. Again, lipids not only disturb the platelet count, it also disturbs the hemoglobin, the RBC parameters, as well as the WC parameters. And therefore, the clinical condition under which the blood sample has been drawn for the evaluation of CBC, one should always keep these things in mind. And the most important thing is that the peripheral examination of the peripheral smear is complementary to the automated cell counter. It should be it's actually a clinical dictum that whenever you are looking at the CBC printout, always also read along with the peripheral smear. Now you can make I've already told you that you can make a rough estimate of the platelet count on looking at the peripheral smear, and this is a good way to avoid unnecessary investigations in the evaluation of thrombocytopenia. Therefore, to conclude, platelet count is a very important investigation in modern medicine. It is a challenge both for pathologists and physicians across all specialties of medicine. Usually what the cell counters give you on the they work on the impedance method and give you the platelets, but this method do not give you a precise platelet count when there is either severe thrombocytopenia or marked thrombocytosis. And therefore, the flow cytometry and the optical fluorescence method are the gold standard nowadays. And therefore, the new generation automated cell counters, they usually they are all incorporated with these technologies. And whenever the platelet count is less, on impedance method, they are again rechecked with these technologies and give you a more precise platelet count. And never forget that examination of the peripheral smear is very important. If you are yourself not looking at the peripheral smear, you should ask the pathologist to report the CBC report along with what he sees or he or she sees on the peripheral smear. And remember, sampling related errors are the commonest cause of spurious thrombocytopenia in a clinical setup. Thank you very much for your patient listening. If there are any questions, I will be glad to answer them. I think there are no questions in the chat box. Okay. And iron deficiency anemia, high platelet count is due to pseudothrombocytopenia or due to reactive thrombocytosis. Now, I think this has been asked by Dr. Neha. Neha, this is in case of severe iron deficiency anemia, when you have marked thrombocyte, microcytosis. So you not have, you can have pseudothrombocytosis. But high platelet count, if you document that the iron deficiency anemia is because of blood loss, then there could be a reactive thrombocytosis. So that both situations can exist. One with severe iron deficiency where there is marked microcytosis, and therefore that could lead to spurious or pseudothrombocytosis. And there could be a reactive thrombocytosis because platelets are acute phase reactions, and patients who have iron deficiency anemia because of chronic blood loss can have slightly higher platelet count to the tune of up to 6 lakhs. Generated peripheral smears reports, how reliable are they? Yes, they are very reliable. Of course, I have not seen in here in India, but way back in 2013, when I was the visiting professor at the Harvard Medical School and Children's Hospital, Boston, I'd seen that one machine, and it was very precise. It was very precise. Of course, the manual examination of peripheral smear supersedes all automation. So they generate very good reports, but again, a pathologist and a clinician will try to correlate his clinical findings with what he examines on the peripheral smear. There's one question that iron is essential for platelet production and function. Then thrombocytopenia should be present in IDA. Then why not usually present in IDA? I think iron has no role in the platelet production. Iron has role in the production of hemoglobin. And incorporation of iron, you can estimate now by a peripheral blood parameter, that is the rat hemoglobin equivalent. And it was one of my earlier lecture I talked about. I think if there are no questions, I just summarize. Basically, it's very important. Now, before you are looking at the platelet, many times the referral comes for either you have high platelet count or low platelet count, and they do not match with the clinical condition of the patient. It's very important that one should recheck. You recheck by different technology, ask the pathologist to examine the peripheral smear. Now, most of the newer the automated cell analyzers, they work on flow cytometry. So that's why they give very precise. But again, the sampling errors is very common in a clinical practice. I think it is the most commonest cause in a clinical setup where the sample is not properly taken by the nursing or by the resident doctor. So one should always pay attention to how the blood is drawn for the platelet count, especially for the platelet count, as compared to the WBC and RBC count. Yes, you are absolutely right, Sudhir. In the periphery, I have told you in one of my earlier lecture, in the printout of the CBC printout, which you get from the rural and semi-urban areas hospitals. No, you have the report, you have seen the reports and the histograms they have. But there is no standardization because there is no rule in India. There is no law as far as the standardization of these laboratories are concerned. And therefore, and because of these, and of course the sampling error is there, and therefore you get a spurious report. So many times when you have a patient who comes for, especially for platelet count, because platelet count, it fascinates the patient and attendants also. The moment they are very high platelets or very low platelet, they will immediately rush to the doctor for an advice. And the most clinical dictum is that please do not give immediate opinion on whatever reports he has brought. Instead, you should recheck and get it verified from a good laboratory, from a better automated cell analyzer, and along with the reading of the peripheral smear. And I think in nearly in my personal clinical practice, I think nearly 1/4 of the referral for thrombocytopenia, actually they do not have thrombocytopenia. They have normal platelet counts if it is done on a more advanced automated cell counter. So, Dr. Soni Saab, in your opinion, which iron preparation is best accepted by the patients? Of course, not related to the topic, but the ferric carboxymaltose, I think it is the best, most tolerated one. There are two IV preparations are available in India. One is I've just forgotten the name. But among the two, we have done also world's biggest trial between the two IV preparations, the rapid iron trial, and we had the first publication in the American Journal of Ops and Gynae. And this product FCM is a better tolerated and as compared to the other one, the other preparation. I just forgotten the generic name. So FCM is I think the molecule which is very well accepted and tolerable by the patient. And any dietary influence on platelet counts? No. So any patient who comes in with suspected dengue with low platelets, whatever milk, goat's milk, and the kiwis, the best of kiwis, in the time of dengue season, no epidemic or mini epidemics, the kiwi they cost 100 rupees a piece. Usually they cost 30 to 40 rupees. And then of course you have the papaya leaves and all these all rubbish. They do not contribute to any, do not have any influence on the platelet count. It's good to see senior physicians, Dr. Vinay Soni Saab, Dr. JPG. Dr. Daria, are you online?
Thank you very much, Dr. Sudhir.
Yes, thank you, sir.
Very nice and very educated talk. Thank you very much. Thanks a lot.
Thank you, sir. It was my pleasure seeing you after a long time. Of course. Dr. Amit or anybody, Dr. Daria, if there are no questions, I think we can conclude the lecture.
Yes, sir.
Is there anybody from the IT? And I think Dr. Tiwari Saab is not online right now.
So, sir, wind up the meeting, sir.